Right. Good morning, everyone. I'm Augustine Pereira, Winter Resilience Lead for in the Office of National Health Protection. We are awaiting two of our presenters who will hopefully join shortly as well. You're all very welcome today to the Acute Respiratory Infections Guideline webinar. I'm joined today by colleagues from National Health Protection. We're also expecting colleagues from AMRIC and in IPC and ICGP join us as well. So hopefully they'll be able to join us on the Teams meeting as well. I'll introduce the speakers as they are going to speak. We're very short of time, and so they will pass over to one another as well. We have Dr. Randall Fowler, Research and Guideline Development Lead, followed by Emma Brannigan, who's the AMRIC Clinical Lead. We hope to also have Dr. Paul Ryan join us, who's the ICGP and AMRIC GP Lead. We will then have Adele McKenna, who's a Senior Epidemiologist within HPSC, and Joan O'Donnell, who's the Respiratory Diseases Lead within HPSC. A couple of announcements before we start. The webinar is being recorded. We hope that we will be hosting the slide deck, but also the webinar on the HPSC website. There is also a dedicated acute respiratory infections web page that we will be having on the HPSC website in the coming days, hopefully by next week. So that is where you will find the recording and the slide deck as well. In terms of questions and answers, we received lots of comments and questions in the process of developing and reviewing the guidelines. So hopefully this webinar will answer many of your questions. So I recommend you wait till slightly later on in the presentations. And if you still have any questions, please post them using the Q&A function on the Teams app. We will collate all the questions and respond to all the queries via email following the webinar. So moving on to the webinar itself, in the next 25 to 30 minutes, we will talk about the winter challenge and also the opportunity that we face during this winter. We'll also talk about how we are trying to realize this opportunity for winter of 23-24. In terms of the winter challenge, last year was the first year we faced a multi-pathogenic winter with COVID in the mix. So we had COVID, influenza, RSV, and in fact, we also had some other pathogens as well. You remember Mpox, IGAS, and some areas also had to deal with highly pathogenic avian influenza cases and clusters. So we truly had a multi-pathogenic winter. And if you cast your mind back to the start of the pandemic, you will remember the phrase test, test, test. We've come a long way now. And last year, we introduced the new testing strategy, which advises testing based on a clinically driven model. And this year, we want to reinforce that message about the clinically driven model for testing for acute respiratory infections. Now, in terms of the opportunity, I hope you have all had your COVID booster jab and also the influenza jab this season. It's really important because it protects you, not just you, your family, but also everyone you're looking after and taking care of. So please avail of this opportunity. The evidence for Tamiflu is well grounded, and over the years we've had lots of evidence substantiating the use of Tamiflu. But in the last 12 months, there's been a lot of emerging evidence on the usefulness of antivirals for COVID, particularly Paxlovid. And WHO updated its therapeutics and COVID-19 living guidelines on the 10th of November, which confirms a strong recommendation for use of Paxlovid to reduce hospitalizations in those at the highest risk of hospitalization. A rapid review undertaken by the Research and Guideline Development Unit also identified benefits of early prescribing of antivirals, both for influenza but also for COVID. The EU Commissioner for Health has also written to ministers across member states, asking that there's an increase in awareness of the benefits of antivirals for all respiratory infections amongst clinicians. So for benefits of antivirals for influenza, COVID, and RSV. And hot off the press, we have the HSC's interim guidance, which was updated just yesterday. And there are two pieces of guidance documents in that. One talking about early prescribing of Paxlovid for those with severe disease, and another one about remdesivir for COVID-19 to prevent severe disease as well. So the significant opportunities in terms of both reducing hospitalizations and mortality and morbidity benefits that we want to realize this winter. And the next few slides, we'll talk about how we're going to realize this opportunity for this winter. I'll now hand over to Randall to talk about the guidance for acute respiratory infections, some of the key points from the guidance.
Oh, thank you. Okay, my name is Randall Parler, and I'm going to just take you through quite a whistle-stop tour of a summary of the recommendations contained within the guidance for testing for RE within residential care facilities. At the outset, just to point out, moving on from the previous iteration of this document that was developed in 2021, there's been quite a detailed consultation process that was taking place with a wide range of stakeholders in order to put the current iteration together. So in recent months, we have consulted with and worked with very closely with a whole range of people involved, for example, within the HPSC, within the National Health Protection Office, including consultants in public health medicine, our colleagues in AMRIC, and within Irish, the College for General Practitioners, area directors for public health, the National RESP SIG group, and also the community support team groups nationally. So there's been quite a lot of consultation taking place nationally in relation to this particular iteration of the document. Okay, so I'm just going to give you a quick summary here of the current recommendations that are contained within this iteration of the document. Just to point out at this stage, if there are any queries, any questions around this, we obviously have a facility there. At the end, we put up some email addresses and contact information whereby we can be contacted for any questions, any queries, or any comments people would like to make in respect of the guidance and of the algorithms. And my own email address is available there as well. So should anyone wish to contact me following this. So the initial recommendations here, we're saying that testing in residential care facilities will include multiplex PCR testing for COVID-19 and influenza as a minimum. So where multiplex testing is not available, so testing for flu and COVID-19 should be taken simultaneously using appropriate swabs. We're noting that NVRL tests for multiple pathogens in other labs may already be testing for multiple pathogens on multiplex PCR systems. When an outbreak is suspected within a residential care facility, it's recommended that to notify the facility's IPC, the Infection Prevention and Control Team, and the area public health team. A public health risk assessment should be undertaken, which will direct the management of the outbreak. What we recommend is that testing of up to 5 symptomatic residents is generally recommended, and that's the same as it was previously in 2022, 2023. When infection with more than one respiratory pathogen is suspected within a facility, additional testing of symptomatic individuals may be required following a clinical or public health risk assessment. So this will be assessed on a case-by-case basis, and the risk assessment will determine the next steps to be taken if additional testing is required. It is advisable that swabs, in fact, it's more than advisable, it's a requirement that swabs are taken on site by trained staff, and that only one swab should be taken per symptomatic resident to test for both influenza and COVID-19 as a minimum. So only one swab should be taken unless the laboratory providing the service is not able to provide testing for both influenza and COVID-19 on the same sample. Okay, so for symptomatic residents, it is recommended that a deep nasal or nasopharyngeal sample is taken using a swab specified as appropriate by the lab providing the testing service. The residential care facility should ensure that sufficient supplies of viral swabs are ordered as soon as possible. The residential care facility may seek immediate advice from the NVRL or local lab, depending on local arrangements regarding access to viral swabs. Guidance in relation to advice on next steps to take if results of the test are positive for COVID-19 and or positive or possible or probable influenza are contained within the guidance document. Additional testing with antigen tests or PCR where confirmation is required may be used to guide clinical decisions. For example, if required to determine eligibility to be considered for targeted treatment for COVID-19 or antiviral treatment or prophylaxis against influenza. Testing of asymptomatic residents is not appropriate, as there is no reason to believe that testing of those who are asymptomatic will assist in managing the outbreak. And finally, if the results of these tests are negative for both COVID-19 and influenza, it is recommended that a clinical risk assessment should be conducted and discussed with public health to determine if further testing should be undertaken. Okay, I'm now going to hand over to my colleague Emer, who's going to take you through the algorithm for residential care facilities.
Thanks, Randall. Can you hear me? That's great.
Yes, we can.
Thank you very much. I don't have control of the slide, so if there's someone can move it on for me, that would be really helpful. Thank you. And colleagues have asked me just to talk through the algorithm for testing in the context of acute respiratory infection this season. And I'm happy to do that. And this is going to be the algorithm that applies for residential care facilities, the principles of which, of course, are relevant outside of those settings. But that's what I'm going to focus on this morning for the next few minutes. And you've heard a little bit of this already, but it's just to guide you through the algorithm. So we've heard already that this is a clinically driven model of testing, and that means that we're testing people, residents in this context, who have the acute onset of respiratory symptoms. So the case definition is set out here. Now, the case definition, of course, is one part of it, and you can see it's the suddenness of the onset of symptoms, and it's respiratory symptoms are the focus: cough, sore throat, shortness of breath, coryza, which is running nose and streaming eyes, and nasal and sinus congestion, and a clinician's judgment that the illness is due to an infection. So it's a kind of a well-established definition at this point and aligns with those from across Europe. However, we know, and you know, in your setting, in the residential care facility setting, that older persons don't always present with the typical syndrome, and therefore you know your residents best, and that can be an important contributor to that bit about the clinician's judgment that the illness is due to an infection. So that can be a change in their baseline condition, it can be lethargy, it can be new disorientation or increased disorientation from the baseline, and there may be a change or a loss in the appetite. And so, especially when influenza, for example, is circulating, or you know that there's an increase in detection of COVID around the community that you're in, and you'll be attuned to that. We all know the environment and the catchment in which we work. Those may be triggers for you to think about doing some testing. And of course, if you have any doubt, you can be in touch with your public health and infection control colleagues. There's a broad differential, and that's shown on the algorithm here. It's on the right-hand side, of both other viral infections, which may be co-circulating with the viruses that we're particularly interested in, and there are other bacterial infections too. Again, I don't have control of the slide, so I wonder if colleagues could just move down a little bit. Thank you so much. So if the person is someone who has clinical signs and symptoms and is concerned to have infection, I suppose the first thing to do is that you don't take your next steps based on the result of a test, because the next steps are to think, well, this person is likely to have an infection that's circulating, and there may be a risk to other people. So we need to start to think about transmission-based precautions, so control measures. How do we prevent this infection transmitting to others? That includes ourselves, our staff working in that setting, and other residents, and perhaps to visitors or visiting staff. So those control measures are to do with recognition of symptoms in others, because there may already have been transmission before the first person was recognized. Thinking about keeping the affected person away from other residents, thinking about whether other people have had their vaccination, although in the actual heat of the development of symptoms already, that's not likely to be an active control measure, but it's important for us to think about it as part of that. Airing and ventilation in the room and the rooms that people are walking through and using, spacing between people, keeping those distances, and of course the use of appropriate personal protective equipment where that is relevant. And then we move on to thinking about the clinical management. So we've decided that the person needs to perhaps stay in their room and that we might be wearing masks as we go in and out to them to attend to them. But then are they ill enough to require hospitalization is the next decision point. And the algorithm takes you in different directions depending on the decision there. If someone is going to move to hospital, it's likely that it's best to get on with that and communicate the need for standard and transmission-based precautions and so forth. But if the person is going to stay in the residential care facility, then it's important that while the control measures are in place, that there is testing undertaken. We've heard already that you should, as part of your planning, know which laboratory facility that your tests will go to and what the mechanism will be for testing. Will it be a single swab that will test for both COVID and flu, and perhaps in some settings for RSV? Or will you need to do 2 swabs simultaneously and so forth? So that should be something that you're familiar with and that you know before you have to go and do testing on an individual. Of course, you should take the appropriate, wear the appropriate personal protective equipment for taking tests from a symptomatic individual. And then there's a decision point about whether the person might need treatment. And typically there is not a good evidence base for initiating treatment for COVID before the result of a test, because the treatment is a treatment called Paxlovid, which is a combination of 2 agents, one of which in particular has significant interactions with other medications. So one would want to know that someone had COVID, and so you would wait for the test result before you would consider treating for COVID. However, you might, if you knew that influenza was circulating, you might initiate influenza treatment prior to knowing a result, and that treatment is oseltamivir, or known as Tamiflu. If you know that influenza is circulating and you have somebody who has flu-like symptoms and you're initiating a test, you may want to also initiate treatment. So that would be something that you would discuss with the prescribers in your setting and consider having that available to your residents. And of course, you'll be interacting with your public health colleagues for advice, particularly if there's more than one individual resident affected and there's concern about an outbreak. And you've heard already that you might do testing of a number of residents, perhaps up to 5, to establish whether there's a single organism, in other words, a single virus in circulation in your residential care facility setting, or whether you might have a couple of different viruses, which is entirely possible, particularly at this time of year. And it's possible, of course, that you will have patients that test, or residents that test negative for both of the key viruses that we're interested in, or indeed for any virus, but that they may remain symptomatic. And it's important that the control measures are continued while the person is symptomatic and for a period shortly after their recovery, usually about 48 hours after the recovery. There are some additional details at the bottom of the algorithm then, which defines a residential care facility for the purposes of this relevance of this algorithm, and some details in the box at the very bottom about the details of an outbreak and the link to public health risk assessment. So I'll stop there because I'm conscious we're short on time. Thank you. I'll hand over to my colleague, Paul.
Thank you, Emer. So hi everyone, my name is Paul and I'm a GP with the AMRIC team. And thank you very much to Rachel, who's doing phenomenal work in the background and using technology and controlling screens. So Emer has very eloquently described a lot of the algorithm. There's a lot of overlap with the algorithm that I'm going to discuss. Now I'm conscious I only have 5 minutes, so I'm going to time myself. So and I've got a message that there's 5 minutes left in the meeting. So we're seeing a lot of acute respiratory infections here in primary care at the moment, specifically over the last 5 or 6 weeks. So I suppose from a definition point of view, it's a sudden onset of symptoms. So, people present with cough, with sore throat, shortness of breath and runny nose, and a clinician's judgment that the illness is due to an infection and not something else. So if they do meet the definition, the main, one of the first questions, are they sick enough to require hospitalization? And if they are, then obviously they're sent into hospital. And then the next question, if they don't require hospitalization, are they at high risk of severe or complicated COVID-19 or influenza? And I talk about them in a little bit, if not to be moving the slide too much. So if they're not, then you follow the advice as for symptomatic individuals, manage as per clinical judgment, and you consider the differential diagnosis of acute respiratory infection. So what are they? They're COVID, influenza, RSV, rhinovirus, parainfluenza, and there's lots of different viruses. There may be a bacterial infection as well, or an atypical bacterial infection, and that's for us to clinically assess. So testing to identify the specific organism causing infection is generally not required. Okay, so and if antibiotics are considered necessary, then we're directed to antibioticprescribing.ie for further management advice. So if they are at high risk, then you can consider COVID-19 testing. So I suppose just to say what we do in the practice I work in is if a patient phones the practice with these symptoms, we advise that they have the antigen test before they come in, if that is possible, and if clinical influenza is suspected, consider starting antiviral treatment for influenza. And I suppose it's just. I suppose one point of note, and Emer touched on as well, that the terms, there's three nuanced terms that guidelines use, and it's important really as for us all to be aware of these terms, and so I'm okay for time to talk about them for a minute. So when the guideline group, whatever guideline group whatever group is involved in developing a guideline, you'll often see, and not alone in Ireland, but internationally as well, they're based on the strength of evidence. There are three terms to be aware of. Number one, consider, and then two, discuss, and then three, offer. Okay, so obviously consider has less of an evidence base than discuss, which is less of an evidence base than offer. Okay, so I suppose just it's important to understand these terms and just to kind of be aware of the meaning of these nuanced terms. So obviously that if the person is positive for COVID-19, you assess suitability for treatment with Paxlovid. You treat as per the HSE guideline, and with children, any decision to treat should be made in consultation with the paediatric infectious disease team at CHI. If there's positive or possible for influenza, you assess the suitability for antiviral therapy, and there's guidance on the use of oseltamivir as well. And with oseltamivir, you do not delay. I'm not going to repeat what Emer said already. I suppose it's very important with regard to isolation. So if a person does have COVID, and like for us, when they come in, it's the knock on, it's that they'll have to advise to stay at home, and although a lot more people were finding, and the recent study showing the news that so much more people are actually working from home nowadays, but that they have to stay at home for 5 days and avoid contact with others from date of onset of symptoms, where the date of symptom onset is day 0. And exit from this period after day 5 is on the basis that symptoms have substantially or fully resolved. With influenza, they self-isolate for a full 5 days from the date of symptom onset. And I suppose another thing with what we're seeing with and even over the last few weeks with a number of patients, you know, the first part of that definition, acute sudden onset, like they present to the GP practice and they say it's like as if they've been hit by a train, just sudden onset like that, and it's typical of your influenza. And then I will. So I suppose just to, I've 10 seconds left. I'll just cover that. If you can just move the slide down to people that are more at risk. So unvaccinated people with COVID-19 in general. So those are the people that are more at risk. Additional risk factors are people with BMI greater than 35, diabetes, hypertension, cardiovascular disease, and chronic lung disease. And risk factors for complicated influenza, so over 65 years of age, pregnancy, kids under 2 years of age, respiratory disease, including those on medication for asthma. And that must be, you know, it's worrying to see that there's such little uptake of the flu vaccine. And, you know, you really want to, we're trying to encourage our patients to have the flu vaccine. And diabetes, immunosuppression, those will be BMI over 40. Those with Down syndrome, and then those with moderate to severe neurodevelopmental disorders. So just to be aware of all these people who are more at risk. I'm sorry, I've gone 30 seconds over, so I'll leave it there. Happy to take questions or if there's questions. Oh, sorry, Edel is up next. Yeah.
Thanks, Paul. Hi, everyone. My name is Edel McKenna. I'm an epidemiologist with the HPSC. And I'm going to discuss today a survey we conducted during the summer on respiratory virus testing capacity and practices in acute hospital settings in Ireland. So just get this to move on. So just a quick run through of the results. So of the 40 hospital laboratories invited to participate, 30 responded to the survey. So the results showed that respiratory virus testing is widely available in acute hospital settings in Ireland, with all 30 responding labs testing for SARS-CoV-2, 29 testing for influenza, and 27 testing for RSV. 28 of the 30 labs reported using multiplex PCR testing for SARS-CoV-2, influenza, and RSV, and the remaining 2 that were not currently using multiplex are planning to introduce it this season. The Expert Express CoV-2 Flu RSV Plus was the most common multiplex assay, but all 28 labs did report using more than one multiplex PCR assay. Singleplex testing to test for SARS-CoV-2 is used by 19 laboratories. And sorry, gone too far. And then in addition to PCR testing, 10 of the 30 responding labs also use rapid molecular methods to test for SARS-CoV-2, influenza, and RSV. And most of the labs are testing for SARS-CoV-2 on a daily basis all year round, and that includes out-of-hours services. Testing for influenza and RSV does occur daily during the winter, but it is less frequent during the summer. 12 labs also reported testing specimens from nursing homes and residential care facilities. And 1/3 of responding sites also use near-patient testing to test for SARS-CoV-2, influenza, and RSV. So 8 out of the 10 are using molecular methods, and 3 out of the 10 are using antigen-based near-patient testing methods, and that's just for SARS-CoV-2 testing only. Most labs are referring specimens to the NVRL for additional testing, and this is primarily for surveillance purposes, but also for additional subtyping of influenza A. And then just a quick look at the recommendations. So the non-responders of the survey should be followed up, and we are hoping to repeat this survey every 3 years. Future surveys should collect data on the reasons for labs continuing to use singleplex tests, and future iterations of the survey should clarify confirmation and notification practices for symptomatic cases detected via molecular-based near-patient testing. Adequate funding and capacity should be made available for all acute hospital laboratories for using multiplex PCR and other rapid diagnostic technologies, and additional work to be undertaken to better understand the testing pathway for specimens from nursing homes and residential care facilities. That work has already been undertaken, and future surveys to include questions that collect data on multiplex testing capacity, so the volume of the PCR tests that can be undertaken by the laboratory each day, both in winter and summer periods. So just a huge thank you to all of the labs that provided the data and those involved in developing the survey questionnaire. I'll move you on now to Joan O'Donnell.
everybody, and thank you for joining the webinar. My name is Joan O'Donnell. I'm a specialist in public health medicine at the Health Protection Surveillance System or Centre. So this was a study that was undertaken by the Health Protection Surveillance Centre. A questionnaire was sent out to the regional health departments of public health and also to the community centres who coordinate nursing homes. And the queries were basically to determine which laboratories were used by the nursing homes for testing for acute respiratory infection outbreaks and how they accessed the swabs. So next slide. Sorry. So this was really the result of the from the regional health protection teams. So the NVRL is used directly for swabs are sent for ARI outbreaks directly to the NVRL in the Dublin area, that's CHO 6, 7 and 9 in the northeast and in the northeast and County Mayo. Then the NVRL is also used via local hospitals in the northeast. So that's all the red in the map there. And then the other health protection teams used local labs. So basically that would be the Southwest, the Midwest, and the Midwest and the Midlands and the Southeast. So next slide. So this is a very busy slide, but the essence of it really is that the labs are the regions that use the NVRL. They're using VTM swabs, that's virus transport medium swabs, because that's what the VRL use for testing for the respiratory viruses. The other regions then are using lysis swabs apart from the Southwest, who also use VTM swabs. And you can see here the areas sending the samples directly to the VRL are the Dublin areas, the Northwest and the Northeast. So in order for the regional departments who use the lysis swabs, they can be accessed through the PPE portals. And it's usually approximately, I think, 10 swabs at a time that can be collected. And then for the NVRL, there's an email address there for the access site for the NVRL swabs. And it goes through the details of how to access the swabs. And you will need to select the Copen swab collection device for viral molecular testing and input the number of swabs you require. The maximum number you can order from the VRL is 10 swabs. And there's a preview button at the bottom of the page which allows you to preview the details of your order. And if you're happy with that, you just submit it. 2 links here, one describing the Copen swab, and that's from the NVRL website, and then a video regarding taking nasopharyngeal swabs is next. And then the request forms, you could download a request form from the NVRL at the link here, the nvrl.ucd.ie.info. And some of the RCFs still use SARS-CoV request forms, which is acceptable, but they must ensure to request RE multiplex testing on that form. The VRL undertakes multiplex testing on all the viruses. That would be RSV, influenza, COVID, plus human metapneumovirus and adenoviruses and parainfluenza virus. So that's the essence of that. That's really the essence of the results. Thank you. I'll hand over to Augustine now.
Thank you, Joan. That concludes our webinar. I might take the opportunity to look at 2 questions that have come up in the process of discussions and review of the guidance. And Joan, if I might put this to you, and can I ask maybe Emma and Paul, you might want to comment as well. So one of the questions that often arises is there a role for antigen testing in managing outbreaks?
Well, ideally, as described in the guidance, it's best to take 5 nasopharyngeal swabs to get PCR testing done, because that will laboratory confirm whether it's flu, COVID, RSV, or one of the other viruses like human metapneumovirus, or if there's co-infections with maybe COVID and flu, which we have seen this season. So the ideal practice would be to get the 5 nasopharyngeal swabs and send it to the lab. But after that, if people are symptomatic, there would be a role to use the antigen test to confirm if it's COVID or not. And principally that would be for the institution of Paxlovid, so that you could implement that treatment as quickly as possible. That would be what I would see as the role, but Paul and Emer may want to add to that.
Yeah, Joan, I don't have much to add to that now, to be honest with you. What I usually say is that whether, like for me, it's within the GP setting, we tend to get people to have the use the antigen test when they're symptomatic before they come in, you know. So
yeah.
I think you've covered it. I have nothing else to add.
I suppose I just want to make one point, though, from the regional public health protection departments, that they would notify all the cases as part of the outbreak. You know, the additional cases as well, whether they've been antigen tested or not, as well as the first 5 that may turn out to be positive from the lab results. Am I making sense
Dawn.
there?
And thanks, Dawn.
It's important to report the magnitude of the outbreaks, is what I'm saying.
Absolutely. Reporting to the public health department is vital. The medical
And
officers
I suppose just to add, at the
notified.
moment, Augustine, there is no antigen test being used for flu or RSV, and the HICWA did a review of that, and there's no substantial evidence internationally to promote the use of antigen testing for flu and RSV. So just to flag that, and obviously, if there's a flu outbreak in the facility and people become symptomatic, it's probably, I think, okay to empirically commence oseltamivir if the antigen test is negative for COVID. But Emer may wish to add to that.
Joan. And so just to summarize that, and I can see Emer has had to leave. Just to
Okay,
summarize
but
that.
Paul, would you agree with that, basically?
Yeah, absolutely, absolutely, Joan. Yeah.
Thank you. And just to summarize that, so if there are symptomatic patients in residential care facilities, please test the initial 5 patients with a PCR test, a multiplex test, and depending on where you are, you can send them either to NBRL or to your local hospital laboratory, as Joan outlined in the previous slide. And once we have a confirmed COVID-19 outbreak in a setting, you could test with the subsequent symptomatic patients with an antigen test. And you can get the antigen test kits through the PCR portal as well, by the way. And if you have a confirmed influenza, once again, you could do an antigen test for COVID, and it might pick up whether you are having co-circulation of COVID or not. If not, quite possibly it will come back as not detected, and you continue to treat as empirically for influenza. So another question.
Augustine, could I just quickly bring in whether I mightn't have emphasized it enough? What I outlined in the slide about the labs being used by the different health, that's going to continue for this season.
That's right. Yeah. Thank you, Joan. So another question is about what does the guidance say about asymptomatic close contacts management in an outbreak?
Well, I suppose from my point of view, we wouldn't really be undertaking contact tracing on any of these cases. We'd just be observing any other residents within the residential care facility to see if they become symptomatic or not, and then undertaking a public health risk assessment regarding follow-on treatments or chemoprophylaxis. But I mean, I think we're past the stage of active contact tracing for either COVID or flu. We would never have done it for flu anyway.
Yeah, thank you, Joan. So
like we're back to business as usual, I suppose. We're post-pandemic.
Paul, anything to add?
No, Joan, yeah.
So there is no place for asymptomatic for testing of asymptomatic patients, and that's the key message here. Essentially,
actually, Augustine, there's a question in here that we had noted before, and it's in the RE guidelines done by Amrit, but Emer's gone now, so maybe it should go to Emer. Louise from the south has put it in there. I don't know if you can see it or not.
Yeah, I'm conscious of time, so we've run out of time, and we'll certainly take all questions and respond to all queries. Please post your queries on the chat hopefully many of your questions have been answered. If they haven't, we will certainly collate all the questions and respond to you with this, our responses either via email, and we can certainly add information onto the website. We will be having a dedicated web page on acute respiratory infections, hopefully in the coming week. So please look out on our HPSC website for further information. So I want to thank you all for attending today. If you have any suggestions for other topics that might be of interest in for a webinar, please let us know. Any questions or queries, you can email the Research and Guideline Development Unit at rgdu@hpsc.ie or myself, and we will certainly be in touch with you. Once again, thank you all for all the work you're doing this winter. That is keeping people safe and protecting people from serious consequences of infection. Thank you very much.